Hello and welcome to this quick review of a topic that I know has been troubling a lot of you, no matter how many times you read it, CD markers. So I'm going to take this really quick review on trying to just remember, review and learn to apply, and that's how you will end up remembering a couple of important CD markers, right? So let's begin. What are CD markers? CD stands for cluster of differentiation. This is us basically trying to tag certain proteins on a cell to try and see what kind of cell it is, whether it's a normal cell, a tumor cell. If it's a tumor cell, what kind of tumor cell. And what we've understood is, after doing a lot of these CD markers, is that every cell, every cancer cell expresses some markers which one will tell us what they are, two will tell us what has gone wrong, and we combine both and then figure out what kind of cancer cell it would be. So let's begin. I'm going to talk about a couple of blood cells here. Whether it's immunohistochemistry or flow cytometry, the CD markers remain the same. The only difference is in the technique, because flow cytometry, look at the name flow, it's used for liquid samples, and immunohistochemistry is used for solid samples. Markers, I'm sure if you remembered, are the same for leukemias or lymphomas, right? So let's begin. Let's imagine a hematopoietic stem cell. So this is a hematopoietic stem cell or a progenitor cell that it forms. On its surface will be expressed CD34. So remember, CD34 is a marker of stem cells, and also HLA-DR, which is we take as a marker of a little bit of immaturity, right? So CD34 and HLA-DR. These cells then give rise to certain precursors like pre-B cells. So pre-B cells retain, because they're immature, remember, they're still immature, they've come from these cells. So they retain CD34 and they retain HLA-DR. So I'm not going to write them again, you know the color scheme now. In addition, they will start expressing CD1920, which will tell me that this is a pre-B cell, it's a B cell. It will also express TDT, which is a marker of, again, immaturity, and CD10, which is also called common ALL antigen, CALA. So this entire picture tells me that the cell I'm looking at is a B lymphoblast, a pre-B cell. On the other hand, a pre-T cell will again have CD34, it will have HLA-DR, it will have CD3 instead, which is a marker of, which is a T cell, which is a part of T cell receptor. So it's a lineage specific T cell marker. In addition, because it's immature, it will also have TDT and it will also have CD10. So that completes your picture of what a pre-T cell would look like. Now let's go to the next cell. The next cell is a myeloblast. So again, since it's a blast, it's a precursor cell. It expresses CD34, it expresses HLA-DR, but because it's a precursor of a granulocyte, especially neutrophil, it expresses MPO, right? And this is all normal expression. Next, what if the cell matures? If the cell matures, it will lose the markers that is expressed because of its immaturity, right? So CD34 gone, HLA-DR gone, TDT gone, CD10 gone. We're left with CD19 and 20 if it's a B cell. Same way, we are left with CD3 if it's a T cell, among other markers, of course. And then we are left with MPO if it's a mature neutrophil, right? There are some other cells, there are some other receptors that can be expressed because it's attained maturity. For example, CD13, which is again we take as a sign of mature cell. Some more cells, some more kind of cells and their markers can be seen. For example, imagine a monocyte, a mature monocyte, which again would have come from a precursor cell like a monoblast. Monocyte also expresses CD13, as well as markers called CD14 and 64. So monocytic markers are 14 and 64. So with this, we have seen what are the markers of immature cells, what are the markers of mature cells, and then what are the markers of different types of mature cells, right? Next. Now we all know that the blood cells are made in the bone marrow. Now imagine that due to some genetic change, the entire bone marrow is full of, quickly, it's, just full of tumor cells, right? So this bone marrow cell, tumor cells from the bone marrow are going to come out into the blood. When they do this, when all the blood cells are spilling out from the marrow into the blood, this is when I'll call it a leukemia. So leukemia is the presence of tumor cells in blood, which is why we will take a sample from peripheral blood or bone marrow aspirate as per the count and run it in flow cytometry to then try to figure out what kind of tumor cells they are, to try to find out their lineage and their level of maturity, right? That's why we learned those previous markers. Next, let's imagine this is a tumor cell and this tumor cell is expressing HLA-DR, sorry, CD34, HLA-DR, MPO, right? and it's also expressing CD13. This picture, when I know is in a tumor cell, I will think that this is a myeloblast, right? Next, it's a tumor cell and it has CD34, it has HLA-DR, it has CD13, and it has CD14 and 64. This is an immature cell. I'm going to consider this to be a monoblast. Next, there's an immature cell, a tumor cell, CD34, HLA-DR, CD19 and 20, and TDT, and CD10. Do you remember this picture? Lymphoblast, B lymphoblast. So this entire picture of B lymphoblast is in a tumor cell. It's in the tumor population. I will start thinking in terms of it being a leukemia, right? A lymphoblastic leukemia. Then imagine there's another tumor population which is expressing CD34, HLA-DR, TDT. But in addition to this, and CD10, in addition to this, it's expressing CD3. So back to T lymphoblast. So if this is the picture and the blood and marrow are full of these kind of cells, my diagnosis will become B acute lymphoblastic leukemia. And if this is the picture and the tumor cells are all showing this kind of picture, what will I call it? T acute lymphoblastic leukemia. So here we took all normal markers into consideration, but the only difference was it was not just one or two. There were lots and lots of them roaming in blood and in marrow, right? So this was BALL, TALL. Next, look at this tumor population. There is HLA-DR, there's a CD34, there's HLA-DR, there's CD13, and there's MPO. And this is completely full of tumor cells with this expression. This is a question for you. Now I'm going to give you 4 options. You have to rule out one by one. Is it AML M0? M0 is undifferentiated AML. Undifferentiated means it's not showing any lineage whatsoever. And the presence of MPO on these cells is a sign of lineage. So it is not M0. M3 means promyelocytic leukemia. M3 means promyelocytic leukemia. Promyelocytic is a slightly mature form of myeloblast, right? So if it has become mature, these markers, CD34 and HLA-DR, would have gone missing. I'll repeat, because if it was M3, promyelocytic leukemia, because it is more mature than myeloblast, the immaturity markers of CD34 and HLA-DR would have gone missing. So this is not the case of M3. M4, AML M4 is myelomonocytic leukemia, and I should be able to see some monocytic markers, but I can't see them. There are no monocytic, no 14, no 64. So I'm left with one option, and that is AML M2, which happens to be the most common AML, right? Next scenario. Look at this picture now. If you notice, we have 2 types of cells. Can you make out? We have 2 types of cells. In this type, there is HLA, there is CD34, there is CD13, MPO, but here instead of MPO, there is CD14 and 64, monocytic markers, right? So this is a tumor in which I have two types of cells. I have monocytic tumor cells, which are immature, so monoblast, and I have neutrophilic cells, which are immature, so myeloblast. So with this in mind, let's look at the options. Our options are, is it AML M0? No, I can see signs of differentiation. Is it M2? No, because I can see monocytic differentiation. Is it M3? No, because I can see signs of immaturity. And AML M4 is myelomonocytic leukemia, which means that this is a case of AML M4. Next case. Again, look at this. I have 2 populations, right? AML M4, myelomonocytic leukemia. Next. This is a case in which all tumor cells are the same. There is CD34, HLA-DR, CD13, and CD14 and 64. I don't see any MPO, no pink MPO anywhere. This is a tumor population which is immature and expressing monocytic markers, which means this is not M2 since monocytic, M3 since I can see signs of immaturity, M4 should have had MPO. This is M5, which is monoblastic leukemia. Right? So I'm sure you guys are following so far. Revision of some monocytic markers, myelocytic markers, and how to put together the markers in order to diagnose the AML. Right? Now, if you followed so far, let's try and do one tricky question. And that is, imagine that there is a tumor population which is expressing CD19 and 20. It's expressing TDT. It's expressing CD34, HLA-DR, and MPO. And this is weird because this tumor population is expressing immature markers, but it's also expressing neutrophil, which is myeloid marker, and CD19, which is a B cell marker. So this tumor population is not restricted to one lineage, right? This tumor population is not a one lineage, it's of mixed lineage, which is why, what will I call it? Myeloid B lymphoid mixed phenotypic acute leukemia. Myeloid because it's got MPO, B lymphoid because it's got CD19, and mixed phenotypic acute leukemia, right? So this was a very quick revision of how to diagnose a little few of the leukemias and their CD markers: CD34, TDT, HLA-DR, CD13, MPO, CD19, CD10, and CD14 and 64. So I hope this discussion helped. Please let me know if there are any doubts. We will meet you again with some more discussions just to help you with your revision. All the very best, and do follow us on the DAMS Tele channel on the YouTube. Thank you so much.